All right, we'll get started. Good evening. I'm Karen Porter, professor of sociology and co-director of the Women's and Gender Studies program. On behalf of myself and my co-directors, Professor of English, Susan Morehouse, and Professor of Modern Languages, Sandra Singer, we'd like to welcome you to the first of this year's talks in the Riley Speaker Series that is dedicated to reproductive justice. We are thrilled to have Dr. Monica McLemore as our distinguished speaker tonight, and you'll understand exactly how thrilled I am once you hear her speak. To begin, as we gather in this virtual space, those of us who call Alfred our home consciously and intentionally recognize that we live and work on the traditional and ancestral lands of the Onondaga, or Great Hill People. This Riley Lecture Series is made possible by a generous gift from three sisters. Pamela Riley Osborne, a member of AU's class of 1962, Patricia A. Riley, a 1965 AU graduate, and Melissa Riley, who went to another college, not Alfred, right? In memory of their parents, this generous gift in memory of their parents. Their mom, Elizabeth Hallenbeck Riley, a member of AU's class of 1936, was an activist involved in issues such as pay equity for women, and according to her daughter, Melissa, would have deeply appreciated this year's theme of reproductive justice. Charles Riley, their dad, was a 1935 graduate who supported his wife and her activism. We are so very grateful for the Riley sisters' support and faith in us to deliver timely and relevant programming, which we've been able to expand to create the Riley Speaker Series. So thank you, Patricia, Pamela, and Melissa. And all three of them are here tonight, along with Pamela's son, Andrew. So please, let's give them a virtual round of applause. So this brings me to my introduction of Dr. McLemore, our distinguished speaker this evening. Dr. Monica R. McLemore is a tenured professor in the Child, Family, and Population Health Department at the University of Washington, and also the interim director for the Center for Anti-Racism in Nursing at UW School of Nursing. Prior to her arrival at UW, she was a tenured associate professor at the University of California, San Francisco, and was named the Thelma Shobe Endowed Chair in 2021. Dr. McLemore retired from clinical practice in 2019 as a public health and staff nurse after a 28-year clinical nursing career. However, Dr. McLemore continues to provide flu and COVID-19 vaccines whenever she gets the chance. Dr. McLemore's program of research is focused on understanding reproductive health and justice. This couldn't be a more timely topic, and as Dr. McLemore reminded us, it will probably be mentioned and featured somehow, some way in tonight's State of the Union. Dr. McLemore is one of the experts in the nation who's called upon to speak on these issues related to reproductive health and justice. To date, she has 96 peer-reviewed articles, op-eds, and commentaries, and her research has been cited in the Huffington Post, Lavender Health, in 5 amicus briefs to the Supreme Court of the United States, 3 National Academies of Sciences, Engineering, and Medicine reports, and a data visualization project entitled How to Fix Maternal Mortality. The first step is to stop blaming women. That article, by the way, was published in 2019, the 2019 Future of Medicine edition of Scientific American. Dr. McLemore's work has also appeared in publications such as Dame Magazine, Politico, ProPublica, and other NPR outlets, and she made a voice appearance in Terrence Nance's HBO series, Random Acts of Flyness. She is the recipient of numerous awards and was past chair for the Sexual and Reproductive Health section of the American Public Health Association. She was inducted as a fellow of the American Academy of Nursing in 2019, but resigned from that academy in 2022 due to inaction on the academy's part specific to the Dobbs decision that overturned Roe v. Wade. Also in 2022, she became editor-in-chief of Health Equity Journal. Dr. McLemore works to advance reproductive justice for all people, and she does so by working nonstop, and I mean that literally, to find new ways and new approaches to overcoming racism and classism and sexism in the structures within which people receive reproductive health care. She is a force, and I am so delighted that she's here with us tonight. It is my honor to introduce Dr. Monica McLemore, whose talk is titled, "The State of Reproductive Rights, What's Changed, What's Next, and What We Can Do Now." Please welcome Dr. McLemore.
Mute. Let's try that. Can you hear me? Awesome, awesome, awesome. So I hope somebody's going to drive now because I was having issues. Well, first of all, before I put my slides up, I just want to thank you for that long and kind introduction. I actually sleep 8 hours a day. I actually do sleep. I don't work all the time. And I will say that Monica Simpson, who is a colleague, collaborator, and co-conspirator of mine who runs Sister Song, the Reproductive Justice Women's Health Collective, will be at the State of the Union tonight. And she will be the guest of one of the Congress people from her state of Georgia, where she currently lives. She's from North Carolina, but she will be at the State of the Union tonight. There was a briefing call earlier today, and Repro is going to be a part of that conversation tonight. It'll be interesting to see if the president will use the word abortion or not. I also know that one of the unfortunate people who have fallen victim to, the unfortunate situation now that Dobbs is the law of the land, the woman who had the miscarriage in Texas who almost died because she could not receive a life-saving abortion, will also be a guest of the vice president tonight. Anyway, it is a huge honor for me to be here with all of you. And I have to say, I have some slides. I've shared them with the organizing team. I'm not committed or wedding to getting through all of them because I'm really looking for fostering a dialogue. Probably take me maybe 35, 40 minutes to get through it. But I want you to know, because I'm in a dual consent state, and I believe strongly in consent, and you'll hear why, because it's an essential component of reproductive justice, which informs all of my work. I am in a dual consent state, California and Washington, both of which I have residences required that I affirm my verbal consent to be recorded for this lecture, so I will do that. You also have my consent, my affirmative consent to screenshot, to live tweet, to do whatever it is to help combat misinformation and disinformation, because for people who know me, who follow me on socials, you will hear me say this often. If Nazis, bots, trolls, and all sorts of other nefarious individuals are the only people who are using social media and other tools to speak directly to the public and the people that we serve, then we can't be mad when misinformation runs rampant. So you have my affirmative consent to use those tools as well. To the students, thank you for being on. I really appreciate the fact that you will be our future knowledge producers, as well as our future creative people who will push us to do better. And to the faculty who are on, thank you so much for taking up the gift and the job to be able to educate the next generation of folk. I will say this, I use she and her pronouns, and now that we're building space and being in community with each other, I really would hope that you would call me Monica. So with that, I have to say I was born a preemie in 1969. My birthday is on New Year's Eve, and it really should be on Valentine's Day. And if you know anything about that time in our healthcare and the assassination of Dr. King and this Black History Month, you would know that I'm lucky and grateful to be alive as a preemie, because at that time, babies who were born between 31 and 32 weeks did not have a good life expectancy. So I'm grateful and lucky to be able to be the nurse who I am, to be the public health person that I am. And from a positionality statement, Everything I do is personal. All the work that I do in reproductive health rights and justice is personal. And in my entire career, just my 30th year in nursing, I look young, but I'm not. I have to say I've only worked with childbearing families, and I've only worked with people with capacity for pregnancy. And you will hear me use that language because I feel very strongly about having gender inclusive language. So with that, feel free to chat. If you are a go away and come back kind of person and you think of a question, but it's like next week, send me a message on social media. If you are a use the chat, kind of person, please put questions, comments, things for me to consider, things for me to think about in the chat. We are going to have a time where people can also raise their hands and unmute themselves, but I want people to communicate. This is really a dialogue. My job in this talk is to honor the Riley Lecture, but it's also to activate you to think differently about some of these issues. And I'll give you the punchline early on, and I'm going to try and convince you that everything we've ever been told about abortion, family planning, contraception, birth, everything we've been talking about, the reproduction and the propagation of the human species, and the ways in which we talk about them in public is inadequate. And it all got us here. And that we need a more literate, a more confident, a more competent conversation that's more nuanced in dialogue. And that's why I love reproductive justice, because it gives us those tools. So I'm going to share my screen. Hopefully you will be able to see it if I don't have any technological issues. I did let the planning committee know that I'm not going to apologize if you see some kittens walking across my computer screen. They're asleep right now, but if that happens, we'll just get over it and move on. Venus and Serena are wonderful kittens, and I just love them to death. So these are some programs that I'm affiliated with. I am a big fan, and I'm a visual learner, so I like to be able to represent things pictorially, and that's the bulk of what my slides are. When I was preparing this talk, I was super excited because I was like, I don't really know a lot about Alfred. So let me look up Alfred and do some work. And what I found out was it is the second, co-educational college in the United States. And it was one of the first, oldest, and it was one of the first to actually enroll African-American and Native Indigenous students. And I thought that was really cool. The fact that it's in super upstate New York was also very cool because my dad, even though he was born in Fort Worth, Texas, he grew up in Buffalo. And my grandmother, before she died at the age of 94, she was on the Dawes rolls. And if you know anything about that, that was the sort of government agreement where Black and formerly enslaved people could claim Native Indigenous ancestry. She was one of the matriarchs that was on the Dawes roll. So knowing upstate New York and really thinking about it in that way, it is so cool to see the gift that the Riley and Osborne families have put forward. My dad, I'm not the first Dr. McLemore in my family. My sister is, and she is a tenured professor at Morgan State University in Baltimore, Maryland. But my dad, my sister, and myself all went to the same college, the College of New Jersey. And so you've given me a really cool idea to replicate your generosity at our alumni institution. So thank you for that, because I think it's really cool. Another thing I think was really cool about Alfred is outside of ordinary is your tagline. How appropriate for somebody like me to be able to come and talk with you. So I'm going to then tell you a little bit about where I am. I'm going to dedicate this talk, since it's Black History Month, to two Black nurses that have been so impactful to me in my life, and I just love them. Our tagline at the University of Washington is Be Boundless. So, for me to be thinking about having this kind of conversation in Black History Month is really important. This is Frankie Manning. Frankie Manning is iconic in Washington State. She just won, this huge award from the Washington State Nurses Association. She's been pushing the cause of Black nursing in the state of Washington forever, and is iconic. And I will tell you that, the dean of the School of Nursing, Elizabeth Sewell, where I currently sit, For years, she had to apologize because she did not allow for Black nurses to study at the University of Washington. So Frankie and her team were instrumental in making that happen. The nurse on the right is from California. This is Dr. Betty Smith Williams. And Dr. Betty Smith Williams was the first ever Black nursing faculty in the state of California. And she became a professor in 1956. So before I left California, I was the lone Black tenured associate professor at the University of California, San Francisco, of 3,516 faculty. So I got a chance to meet her in person when I was inducted into the Academy of Nursing. So this talk is for them. I hope I can continue to make them proud and build on the legacy that they've created. My land acknowledgement is different since I'm in a different part of the country. And I have to say my house is seated right on the coast of the Coast Salish people. And I take land acknowledgements very seriously because I think at some point we need to have a conversation about, returning the land to its rightful owners and what that can look like in an equitable and fair way. For those of you who don't know, reproductive justice was started in 1994, and it was in response to the framing that choice was too narrow to talk about the lived experiences of Black, Indigenous, and Native and other people of color, right? And it's interesting because of the 12 founding mothers of reproductive justice, 9 of them are still alive. One of them is a postdoctoral fellow with me, Dr. Tony Bond, and one last year, Professor Loretta Ross, who's also working on her PhD, is a tenured faculty member at Smith. She won a MacArthur Genius Award last year. So we talk about reproductive justice in the context of it being a theory and a praxis and, an organizing frame and a strategy, but like most of these people are still alive and working. So I don't want it to become an abstract construct because it guides a lot of my work. Many of these people are still alive. And I like to give people their flowers while they're still alive. So I'm going to give you some background that I think is super important because you can't talk about why would we need reproductive justice? Well, this comes from a textbook on the social determinants of health and understanding social inequity or equity. And it's a public health textbook. And we have to talk about where the disparities of distribution and disease and illness and wellness come from in a population, right? I'm a public health person, so I'm always going to look at these things from a 30,000 foot view. Like social determinants of health don't just fall out the sky. Whether or not you have safe and affordable housing or a living wage or quality education or transportation, like they don't just fall out of the sky, number one. Number two, social determinants of health are not negative. They're always talked about in the research literature, and I find that people talk about them in the negative because it's the lack of safe and affordable housing, it's the lack of a living wage, it's the lack of quality education, it's the lack of transport, but they themselves are inherently not negative, right? So if that's true, then that means that they can be, adjusted for, it can be fixed. So where do the social determinants of health come from? Well, they come from policy decisions. Right. So if you look at power and wealth imbalance, you look at our tax policies, you look at the loss of our social safety net, you look at what's going on in Florida right now with the educational system, you look at housing policy, these are policy decisions. So whether or not social determinants of health are positive or negative is dependent upon what your policies look like. But if you go to the upper strata, you will find that like 3 things really dictate what policy is. And those 3 things are patriarchy, misogyny, institutional racism, and gender oppression. Right? So when I talk to students, I try to get them to understand like social determinants don't just drop out the sky. Right? These are a result of policy. When you think about redlining, when you think about the chronic underfunding of public hospitals, the chronic underfunding of public schools, you don't even see the military on here, right? So when you think through where these things come from, it's important that we all get on the same page so that we can have the same discussion about what the actionable solutions are in order to fix all of these. That's why reproductive justice is really important. I haven't defined it yet, but I will in a minute. So let me go back because clearly I'm skipping slides. Okay. So take home point. Social determinants of health are neutral. and they are actionable. We can do stuff about them. So people always say to me, oh, well, you know, that's just poverty. I'm like, even poverty is a policy choice too, right? We found that out during the pandemic. That's quite possible to send people money to live on and be able to have our universe like not stop. Okay. And then health disparities, health inequities, all of these arise from structural racism. I say this to people all the time, and they're like, Dr. McLemore, what do you mean? And I'm like, well, the differences that we see among and between populations, right, is actually like, it arises from our inability to invest in our citizens. And how do we invest in our citizens? Well, when we want to allocate human, money, space, and time resources, who makes those decisions and how do they get made in a democratic society, right? That's why voting rights are a reproductive justice issue. Anyway, health inequities persist because of structural racism. And quite frankly, you know, because everybody, like, immortality is not an option for our species, right? So everybody wants a dignified life and everybody wants a dignified death. And so how that occurs is really, in my view, a result of policy decisions and how we allocate human money and space and time resources. Okay. So let's deal with some nomenclature, because I've thrown some terms around. I haven't defined it and I hate it when people do that. So I'm not going to do it. Reproductive rights are legal frameworks, right, that basically should provide like protections for our citizens. Now, the way our country was found, it makes our rights negative, right? So if you think about it, we was fleeing a monarchy. And so that's why we have freedom from government. We have freedom to, like, so our rights are kind of negative just because of the jacked up way our country was founded. But like, reproductive rights are legal protections that citizens should expect. Reproductive health is like when I go in a room and I introduce myself to a patient and I'm like, okay, we're going to do your pap smear today. We're going to do your breast exam, testicular exam. We're going to test you for sexually transmitted infections, blah, blah, blah. That's reproductive health, right? Reproductive justice is a completely other way of thinking about how we want to organize resources, human money, space, and time. And it has to do with the fact that, like, it solves the problem of reproductive oppression, and that there's multiple oppressions. And we have to connect all of this to the struggle for social justice and for human rights. So, briefly put, reproductive justice, you'll hear people say, oh, it's the right to have children, to not have children, and to parent children in healthy and safe environments, right? That's not how I talk about reproductive justice. That was the original conceptualization. The way I talk about reproductive justice is, it is every person has the human right to decide if they want to make family and kin, and under what circumstances and situations to be able to have that occur, and to have all the dignities and supports that's necessary in order to be able to do that, right? So that brings in infertility people, but that brings in non-human folks, that brings in care of the environment, that brings in a whole lot of stuff, right? Okay, then I say every human has the human right to end and or prevent pregnancies in any ways that they see fit, with all the dignities and supports that are necessary in order for them to be able to do so, right? Then I talk about the fact that, every person has a human right to be able to raise the children that they already have in safe and healthy environments, free from any violence from any individual or from any government, right? So that sort of like puts us in the domain of whether you're carcerally involved, you should not have to, like, meaning you're in jail or prison, you shouldn't have to relinquish your parental rights because you may or may not have committed a crime, right? Or if you are parents in Ukraine, you shouldn't have to worry about violence from another state. So it broadens this aperture for us to make different arguments, different conversations. The fourth tenet that I add to reproductive justice, and it comes from, Southern organizers and other people, is that we have a human right to disassociate sex from reproduction. And we have a human right that allows us to understand consent and healthy sexuality and pleasure, because trial and error should not be the ways in which people understand contraceptive methods and how they work for them. Trial and error should not be how people figure out what their sexual orientation and or their gender presentation is going to be. Like, we can do better than that. So that's how I think about reproductive health, reproductive rights, and reproductive justice. And in my mind, they're interrelated concepts, but they can't be used interchangeably because there's different approaches that are necessary. One of the reasons, how we got to Dobbs is too many people relied on legal arguments in order to be able to win the hearts and minds of people. Too many people relied on healthcare arguments at the time when we actually needed legal ones and scientific ones. So for me, making these distinctions really matters because it changes up how we how we strategize, but then how we also like move and what actions we take on. So I'm gonna pivot for a little bit because I want to define 3 other terms, and they're all ours too, right? Retrofit, reform, reimagine. Dr. McLemore, why would you want to define these terms? Well, because I wrote about this framework because this is the only way we get towards health equity, and reproductive justice is the path. Right? We're never going to resolve the Black maternal health crisis and maternal morbidity and mortality, and everybody can roll those statistics off their lips, right? Black women are 3 to 4 more times more likely to die from pregnancy and childbirth related complications. Like, people have some awareness around that, right? But we're never going to get to health equity if we don't understand that reproductive justice is the path that we need to use in order to get to health equity. So in order to get you there, I need to give you some other definitions. These come from Merriam-Webster. So if you got to go get water or go to the bathroom, whatever, these are straight out of the dictionary. Do you? Retrofit. There are 3 definitions in the Merriam-Webster online dictionary. I like the last one to work through this framework. We are trying to adapt to a new purpose or a new need. You want to retrofit a story for a new audience. And because I live on the West Coast, retrofit has a very specific meaning because of the earthquake and, word of silence to the survivors in Turkey, Syria of the earthquake that just happened, right? But retrofit, to actually, have a new purpose, a new need, that let me tell you something about retrofits. The inherent structure is not going to change, right? Let me give you an example around this in reproductive health rights and justice. As long as healthcare financing in the United States is dictated by insurance, we will never see reproductive justice, the kind of like everything that we try to do is a retrofit. Why is that, Monica? Because if you receive your health care at a religiously affiliated institution that does not believe that comprehensive reproductive health care is a human right of yours, that's not going to change. So anything that we do in that context of healthcare financing is a retrofit. It will never be a reimagination or reformation unless some other catalytic event occurs. So retrofit. Reformation or reform. There's 4 definitions. I like the first one in Merriam-Webster because this is the first time that you get to change something and or remove something. In healthcare, we're always adding things. I will never forget when we went to an electronic medical record, we were still using paper because people didn't want to let that go, right? In healthcare, we are always adding. We're not ever asking ourselves, what can we stop doing, right? Reformation is different than a retrofit because in a reformation, the inherent structure can change. We can take something away, we can change. So when we're having conversations about reproductive health, reproductive rights, reproductive justice, the FDA did approve people's opportunities to be able to get medication abortion during the pandemic without visiting a provider. Imagine that. We can trust pregnant, capable people to take a pill at home, right? So reformation, you can change rules, you can get rid of things. Reformation is a different kind of conversation. Reimagine. We all love to reimagine things. I know I do. This is the space of dreaming, right? We want everything to be different. We want to imagine anew. We want to recreate the world to be more just and equitable, right? A lot of people spend a lot of time on Team Reimagine. Here's the problem with Team Reimagine. So in the same way that retrofit, the inherent structure doesn't change. In reformation, you can change structure, but that means you got to get consensus from a whole lot of people. The problem with Team Reimagine is there's no accountability. You can sit and daydream all day, right? The problem with Reimagine is the people in the now need help. We can't spend all our time daydreaming about the utopia that doesn't yet exist and ignore the people in the now, right? This is going to be the frustrating thing when we talk about police reform tonight, because one of the things that was said on the briefing call is that the president is probably going to highlight reforming police in the United States without defunding them. And I'm like, those 2 ideas are incongruent. So dreaming about building a utopia doesn't get you to how you get there. So one way to think about retrofit, reform, and reimagine is retrofit is reproductive health services provision. Reformation is reproductive rights, the legal protections, but reproductive justice is that reimagination. It's one way to think about where do we go from here now that Dobbs is the law of the land and Roe is not the law of the land. How do we hold on to infertility benefits for people? How do we get people appropriate miscarriage management? How do we take care of people who are going to be forced to carry pregnancy, term, and birth, against their will? How are we going to redesign healthcare and health services provision and the social supports that are necessary to mitigate those health inequities where we're seeing those rises in maternal morbidity and mortality? How are we going to do that? That's the question. So for this audience, since this is a social science, women and gender studies group, I also have to, and sociology, anthropology, psychology, demography, context matters. How we got here matters. So let me just state out the gate that Margaret Sanger was trained as a nurse, and a lot of people don't know this about her, but yes, she was a registered nurse. And in fact, she was part of the New York City Henry House Public Health Nursing Lillian Wall situation. And so it's very important. Reproductive justice also posits that multiple futures exist and two seemingly incongruent things can be true at the same time. And so as a nurse, I always feel like I have to own the good work that Margaret Sanger did, but then also chastise her for her problematic stances and then later becoming a eugenicist, because that's the problem, right? So we have to hold that tension of opposites. You do really great work, but you're a really horrible person. Or, you subscribe to really harmful ideas, but you actually still do really great work. We have to figure out better language to be able to talk about that. From my own work with the Birthplace Lab, you will notice that in any kind of reproductive and pregnancy and childbirth related care, 1 in 6 people, regardless of their race and ethnicity, experience mistreatment. And we define mistreatment as being shouted at or scolded by their healthcare provider. These are data from the United States, just to be very clear. These are not international data. They are from 2,938 survey responses, heavily weighted for Black and Brown participants. I think the sample was 66% Black, Indigenous, and Latinx folks. Failure to respond to requests for help on 1 in 6 people, regardless of what your race or ethnicity was. This includes white people, right? You know what this tells me? And these data taught me a very important lesson, that patient mistreatment and clinician burnout are 2 sides of the same coin because our workplaces are inhumane. And that's especially true in reproductive health rights and justice. Right? People who are now mad that we see people blowing up substations and folks attacking public infrastructure. Where do you think those folks hone those skills? Right? Bombing abortion clinic, violently threatening. I mean, this is not rocket science around where that threat and those intimidations come from in terms of assaulting clinics and healthcare workers. We're seeing some of that now, or shutting down gender affirming clinics, threatening people at Brigham and Women's, around their the work that they've been doing in health equity to improve cardiovascular referral in the emergency department, right? Having death threats for Black pediatricians at Children's Hospital in Boston and Children's Hospital here in Seattle. Right? All of that was honed in reproductive health rights and justice, and the rest of healthcare let that happen to us. And so as we move forward and thinking about repro, we also want to be thinking about where are the collaborations and the connections that we can pull together that will be necessary to push back against some of this violence, some of this mistreatment, some of this inhumanity. When we think about violations of physical privacy, when we think about ignoring women and pregnant people, we're seeing this happen across the country, especially around miscarriage management and people who are in that gray window. It's like, how sick do I have to be in order to have a life-saving abortion? That's really a problem. But then we also see it on the side of, wow, I'm having, numbness and tingling in my legs, and people are being sent away from emergency departments and going home to die from wanted pregnancies because we're all not listening. We're not using a reproductive justice patient-centered approach to really be able to hear people's expertise. This is a piece that was referred to in my intro. I did this in Scientific American. It's freely available if you go through the Black Mamas Matter Alliance website. I said to SciAm, they originally wanted me to write a piece called The Root Cause of Maternal Morbidity and Mortality. And I said, no, I can't write that paper. And they said, why? I said, because if I'm the only living Black person in a piece about Black maternal health, that's a problem. Especially when we know that, at the time, the data from the Centers for Disease Control and Prevention taught us that estimated between 60 and 80% of maternal health were preventable. Now we know it's almost 100 based on updated data from 2019 prior to COVID-19, right? So why would I write a piece around the root causes of maternal morbidity and mortality when we know that there was a solution? So they let me change the title, they let me change the focus. The only thing they wouldn't let me change, and I was very grumpy about this, was the future of medicine. Because I told them, I was like, look, I'm a nurse. I don't work in medicine. Medicine is one discipline of healthcare, and I work in nursing. Can we change it to the future of healthcare? And they said, no. And I said, why? And they said, because it's been named that for 185 years, and we don't want to change it now. It's like, okay, I can understand. I wrote this. You'll notice is dated March 26, 2020. I stand by every word. There were people who were mad that I published this, and this was in Scientific American as well, because they were turning away doulas and other birth workers and supports and family members. They were turning people, and don't get me wrong, the height of the pandemic in New York City and Cuomo and all of that, like, I understand what was happening at that time. But prior to COVID-19, and this is going to be very important for us to understand in Repro, prior to COVID-19, pregnancy and childbirth was the #1 reason why people were admitted to hospitals and healthcare institutions in the United States, because we have like 4 million births, right? Let me say that again. Prior to COVID-19, pregnancy and childbirth was the #1 reason why people were admitted to hospitals and healthcare institutions, because we have 4 million births, right? We have over 100,000 deaths per year from cancer, and not diagnoses, but deaths, right? And we have, 250,000 cases, new, incident cases of cardiovascular disease. Pregnancy and childbirth, the healthiest people in our society, right? Because pregnancy and childbirth are not diseases. So to say that if you are brave enough to propagate our species during a pandemic, that you need to do that alone, there is something wrong ethically and morally with us that we couldn't figure out better ways to be able to assist childbearing families during that time. And so that's where a lot of the drive-through baby showers came from, the auxiliary maternity units in hotels, right? We did a lot of that pilot work because we thought it was really important to make sure that birthing people, especially in the midst of increasing maternal morbidity and mortality, have the supports that they needed in order to be able to safely come through that experience during a pandemic. That shouldn't have been novel. Apparently, this is going to get talked about tonight too. I can't believe, as a high-income country, we say we care about childbearing families. We know that 40% of maternal deaths happen in the postpartum period, but we as a country can't agree to have paid family leave and paid postpartum Medicaid coverage. Like, what is wrong with us? And I want us to have a deep look in the mirror. I say this to people all the time. I had a woman in one of my research studies. She was her primary income was driving for Lyft and Uber because she had a husband who had a good job and employer sponsored health insurance, and her mom had cancer and she was the primary caregiver for her mom. She got pregnant, her husband lost her job. Don't you know, 10 days after a C-section, she was back driving for Lyft and Uber. You know what the worst thing you can be doing after a major abdominal surgery is sitting for 8 hours, and let alone sitting in a car. And can we get on the fact that you have to bond with your new infant and lactation and breastfeeding? And what about your relationship with the co-parent? And how do we deal with the whole family unit? That's now changed. But because she needed money, right? Can't we as a society do better than that? Can we give people postpartum coverage, please? I mean, I'm also asking, can we move pregnancy-related coverage and insurance out of the disability pot? Can we do that? Right? Again, going back to what can we retrofit? What can we reform? What can we reimagine? Those are the kinds of conversations I'm hoping to see between social scientists and clinicians and policymakers, because that's where we're at. We have a prime opportunity to do this now, and I hope that people will. I always tell people this too. Abortion is messy. I have data on this. I published. I'll show you some manuscripts. Every slide I've showed you in the last 8 slides, none of these are scientific articles. These are all translation of database pieces that we wrote for the public in popular press. I'll show you the scientific articles they're based on. But the last 8 slides have all been written for the public. We have to translate our work so that the public can understand it. We can't just publish behind peer-reviewed. I mean, I have a lot of peer-reviewed publications, but if you don't translate your work, then how do we expect the public to understand where we're at? Right? Especially with the, debunking and the closure and consolidation of news outlets, right? So we have to think more creatively about how to use the tools that we have in order to be able to better inform the public and to partner with them about how to make all this different. Because I actually believe it can be different. And I think we have the collective and creative wisdom to be able to figure this out. But it has to be collective and creative. Right? Okay. So let me say this, because I think it's really important. We've had a lot of rural closures of obstetric units. This is a good friend, Katie Casamano, who I just love. She is a health services researcher at the University of Minnesota. She's been sounding the alarm on these hospital closures forever. And I think in the context of jobs, this is going to be a real problem, especially in very rural areas. Then we now have these abortion restrictions where, it's if you're lucky to have access wherever you live. And I actually think that that's not, regardless of how you feel about abortion, I actually think that is cruel, right? I don't use the language of, culture war and violence. People who provide abortion care, people who support people needing abortions, people who support gender affirming care, people who support people who need contraception, people from reproductive justice and who want to support people to have a whole human life and healthy sexuality and to have a reproductive trajectory that's congruent with their hopes and their dreams. We lead with love. We don't lead with war and violence. So how are we now going to create and curate a space where, regardless of what you think about these outcomes of pregnancy, that we can keep our focus, our sharp focus on the people that we serve, right? I want somebody to deal with the public charge, changes in the conscious rules, the crisis pregnancy centers or the pregnancy help centers, Title 10, which is the federal family planning program that was signed into legislation in 1970 by Republican President Richard Nixon. I want us to have a whole different conversation about federal funding and what people deserve in terms of the supports that they can and should have, as a reproductive trajectory, as healthcare, as health services provision. I want us to trouble that entire discussion because in some states, Ohio and Indiana are 2 really, really good examples. The crisis pregnancy centers and the religiously affiliated centers are getting more money than the public health department is from Title 5, which is the block grants for maternal health, and Title 10, which are the family planning grants. I would like to start to see some FOIA requests, federal requests for transparency around how are those dollars being spent? And are people having access to evidence-based information and all the FDA approved methods for contraception? Right? We need to start having those uncomfortable discussions around how to get people what they need in order to be able to operationalize and maintain bodily autonomy across a reproductive trajectory. I think that these are simple questions that we should be asking. I was really grumpy when Serena Williams told her birth story. So she and Beyonce are near misses. So we already know the pregnancy statistics in the United States are bad, but there's like 50,000 near misses every year where people don't die in pregnancy and childbirth, but you have some kind of intervention that's necessary enough where you almost die, right? I was horrified to find out that my own home university, we had like misinformation on our website because information moves so fast, but our legacy websites are outdated. that I pushed them to say, you know, we should just put skeleton information on our website, and then we should push people out to our social media such that as science changes, people can get up-to-date fact-based information. When Beyonce told her pregnancy story to Vogue that September, after Serena Williams talked in January about almost dying, she talked about toxemia of pregnancy. And when you look that up, you know, people didn't recognize that it was eclampsia and preeclampsia. And our own website, even at a prestigious university like University of California, San Francisco, where I was at the time, we still had that ending the pregnancy resolved preeclampsia, when we know that's not true now. We know that people can have preeclamptic events in the postpartum period. So because their blood pressure doesn't necessarily recoil back to normal levels as immediately as we would hope that they would. So in some small percentage of the population, you can actually still experience eclampsia, despite the fact that pregnancy has ended. So ProPublica did this whole really cool piece on, okay, well, so what websites have, you know, inaccurate information? And so we used our professional organization, our journals, to actually come to some agreements around, let's make sure that we have a consistent way that the public, who funded most of this research anyway, because that's what the NIH and other federal funders are, that they have access to evidence-based information that will allow them to understand these conditions and to be able to look for the early warning signs that would allow us to be able to save lives. So if you have near misses, we've got decreased access, we have increased inaccurate information on websites. And then you have some people who actually think that there's a difference between biological race, which is a lie, right? Because the only thing that Black and brown skin does is overexposure to racism and other upstream factors that will ultimately impact your health. We will be in a situation where we have continuing pregnancies that otherwise would have been prevented or ended. And we'll have increases in maternal morbidity and mortality and near misses because of the Dobbs decision. So let's apply a retrofit, reform, and reimagine to think differently about where we are and how we got here and how we can get out of it. Well, one retrofit for the loss of obstetric services, let's reopen those units. I've told the philanthropic community this, you know, here in Washington State and California, my previous state, we can reopen those units. We can think about like the reformations that need to occur. We can train other staff. We can have, because when you lose an obstetric unit, you lose OB triage. I'm like, what happens to those nurses? What happens to all that clinical expertise? What happens to the connections to social services and social support? Nobody can answer this question. So I teamed up with my good friend, Dr. Lisa Wolf, who is the research director for the Emergency Nurses Association. And I was like, let's do a national study to try and figure out, are emergency department nurses prepared to pick up, you know, this slack when, you know, labor and delivery units close in hospitals? And what did we find? Of course, they're not prepared. They never had to do it before because they could always send people up to OB triage. So we created a training program so that they could feel competent and confident to be able to do that. What's home visiting doing? First place people I went to, I was like, okay, so we have nurse family partnership in all 50 states, and we have home visiting of people. Well, can we train them to understand the signs and symptoms of deterioration? Right? We need to rethink about birth settings, and can we create more birth centers, and can we have more midwives, and can we have some more auxiliary maternity units? Let's do that. So now we see some movement towards having those conversations. There was some uncanny consequences of Dobbs. And now I find myself in rooms having conversations that people didn't want to have like a decade ago. Or when you think about the opportunities that the pandemic opened to us around telehealth, it's been very fascinating in my 30-year career to now see things accelerated that I've been working on for like 20 years. And we have an opportunity if we have the courage to be able to be curious. This whole like crisis pregnancy center, Title 10, family planning, all of it, like we need to start having some really uncomfortable conversation. Okay, so now I say this to anti-abortion people all the time. I was at Harvard, last week asking this question to the pro-life caucus. Okay, y'all won. So where's the new introductions of policies to restore the social safety net? Right? Can we come together on paid family leave, or is that like a no? But what about supporting dads and like, you know, other constellation of family members around a pregnant capable person? Or can we think about getting everybody a doula? Let's start there. Like, where can we start that discussion? And where are you prepared to show up and put some resources behind? right? It's really opened up this very interesting opportunity. Or in the context of mistreatment, right? We need safety bundles. We need trainings. We need practice space. I say to healthcare providers all the time, we proposed a simulation space where people can become upstanders and bystanders. Looking at that sad situation with Tyree Nichols, nobody talked to the EMTs and said, hey, do your job after 19 minutes. Like, nobody said anything. Why are we in these situations where nobody says anything? Because nobody knows what to say. And we need to train people how to do that, right? This comes from the marriage of social science and health science and public health and policy, right? Then let's train people how to be upstanders and bystanders. Our colleagues in, sexual assault prevention and sexual violence prevention, they've been doing this for years. This is where teams is very, very helpful, right? This near misses situation, we have to listen to people. We have to listen to their story in real time, not after the fact. Serena Williams should not have had to, write an op-ed in CNN and tell her story to Vogue and all. We should be listening to people and training people how to listen in real time, right? This is where women and gender studies is so important. Narrative, storytelling, right? Developing those skills of being able to sit with people and witness their lives. It's important. Again, I'm a big fan of simulation and practice. We need to be doing this more often as a society, because people need to have safe spaces to try stuff out, even if it's ridiculous, right? We need safe spaces to screw up, because that's going to happen, whether you're talking about reproductive justice or anti-racism work. So let's create that. I am curious enough to think that we're going to be able to do this at a panel at Academy Health when it's here in Seattle in June. Why not? We have to have we have simulation space for hemorrhage. We have simulation space for all these clinical things and pulling the team together and checklists and knowing what folk can. We can simulate behaviors associated with social and reproductive justice. I believe it, right? And then we need to involve the people that we serve, right? I always say to people, if we wanted to fix the healthcare crisis, we would build pipelines to the people that we've previously served, right? Can you imagine how powerful it would be if you became the employer of choice of people who had previously used your services? Where you can say, wow, 33% of our employees actually had their babies here. Or, 33% of our employees bring their parents here for care. It's equivalent to when you go in a restaurant and you ask staff if they eat the food. Right? It's one of these ways that we can start to think about, and I know that people are mourning the loss of Roe. Don't get me wrong. That grief, people need it, but we also need creative people thinking right now. We need creative, because there's harm happening in the now, and we need to reduce it. On this inaccurate information, I was so glad that we were actually able to do the fact-based information for 15 minutes on Fridays on Instagram. We've been doing, me and my research group have been doing Fridays on Instagram Live, really trying to get fact-based information out about the vaccines and COVID and hand washing and distancing, and doulas and pregnancy and menopause. We added a whole menopause thing last week. We just want to be able to get people trusted sources to get fact-based information, where to go to for, scientifically accurate information. It's one of the reasons why I did the We Are Greater Than COVID series for the Kaiser Family Foundation. People were like, you're really going to film a public service announcement? Yes. We need to be able to talk directly with the people that we serve to give them the tools they need to be able to take good care of themselves and their community. So every picture I've not shown you one scientific article. Everything I've shown you has been stuff that's been written, developed, and in partnership with community and for the public. But let's change the narrative. Let's use some data to change a narrative. These are all scientific papers that I wrote with colleagues, collaborators, and friends, because I really wanted to change the narrative around who are the people who seek abortions and why. How can we improve their experiences of their care? What does the workforce look like that we need in order to be able to provide good care, right? This is the paper I mentioned earlier around the 3R framework. How do we retain and recruit people? I've said for years, we're starting too late in repro. You can't wait until people want to be a midwife or a physician to get them excited about working in reproductive health rights and justice. right? We have got to start in K through 12. And we've got to have, sex education, evidence-based sex education for people, how our bodies work. Why do you even want to propagate the human species? And does that matter to you? Right? What does it mean to be a sexual being in a strange world? Right? There's all these places that we could actually really help people make decisions about their lives that can really elicit their preferences, that can help them to understand how to become that creative, full person they want to be. We can also talk about the global impacts of what's going on here, because we always, not only do we export our goods and our services, we also export our harms, right? This idea that we have to always say we can send money to USAID around repro, and then we can't. And then we have gag orders where we can't talk about the full scope of reproductive health rights and justice, and then we don't. And all this shifting, that makes things very unstable around the world, not just here where we are. And at some point we will take our stewards, as what was a founding, and visionary democracy. We're going to take that seriously, because we're like, rebuilding other countries, whether it's Afghanistan or Ukraine. How about we clean up our own backyard and we use reproductive justice to do it? Because that would then allow us to export brilliance, to export the strategies that have worked, right? When we think about comfort and comfort care, again, people who seek abortions deserve our love, our empathy. What are the practices that people need in terms of presence and consciousness? Some people want to be wide awake before abortion. Some people want to be knocked out. Some people want a medication abortion because they think that is a more natural approach. How can we meet people where they are? That's my job as a teacher, as a nurse, right? How do we think about our attitudes and how they shape our willingness to engage in care? For me, these data show nothing. There is no majority group around abortion attitudes in nursing. There are some nurses who are very anti-abortion. There are some nurses who are very pro-abortion. But the bulk of people are in the mushy middle, just like the rest of the American public. And that's okay. But how can we have that conversation and reject the false binary that everybody wants us to sit in? How do we reject that? We found that 66% of the nurses who responded to our survey, this is a national survey, by the way, with the Association of Women's Health Obstetric and Neonatal Nurses, the largest professional organization representing the interests of 350,000 nurses across the country, right? 66% were in the middle on an abortion to attitude scale, which meant that under some circumstances, they really felt that there should be some restrictions, and under other circumstances, there should not be. But when are we going to have this discussion, right? When are we going to disrupt a binary that we're polarized, when data show that's actually not true, right? We wrote this paper, and this is from one of our midwifery postdocs, who's currently at the University of Knoxville, Tennessee. She wrote about like labor and delivery nurses, neonatal nurses, like that middle group. She qualitatively looked at all of their comments. And you know what? It's messy, right? I'm a childless by choice person. I never wanted to be a parent. I'm glad I've never had to make a pregnancy decision. That was very clear to me at 14 years old, but it's not like that for a whole lot of other people. There were nurses who wrote dissertations in our survey, and this was an online survey. They had a free space to type whatever they want. People wrote long things about their infertility journey, about their adoption stories, about their multiple miscarriages, and that informed their attitudes about how and why they would or would not participate in abortion-related care. It had nothing to do with their personal or moral or ethical thoughts about abortion. Many nurses felt it would be too triggering for them to be able to do, given their own experiences, but they were very clear to say, but I support reproductive rights, right? This is complicated. So how do we create language that allows our society to reject the binaries and to be able to talk about these things? Because these are complicated and they're messy, and there's no one solution. My recent work has really been looking at racial concordance midwifery. I'm going to be doing 2023 is the year of Black midwifery for me. So I'll probably be in a 6th amicus brief to the Supreme Court, definitely in the expert opinions and making sure we codified abortion rights in the state of Minnesota's constitution. I was the lead scientific expert in that case, and I'm the lead scientific expert in another 10 around the country that are going on right now. Really putting some science behind, some patient stories behind. Why is this a violation to pregnant, capable people? And why is this a violation to midwives? I'll tell you why. Because any pregnancy decision comes with risk, right? We've known for years that abortion is 14 times more clinically safe than carrying a pregnancy to term. We've known that for years. So all pregnancies end, and no pregnancy happens without some level of risk. And I am of the mindset, and science backs me up around this, that the only true arbiters, the only people who can make these pregnancy-related decisions since all pregnancies end, is the person taking on said risk, right? So we have currently, legally, bodily autonomy in life and death. Nobody can go dig up your corpse and take your organs without your consent, right? So if we as a society continue to believe that humans should have bodily autonomy in life and in death, then in my view, the only true arbiters of any pregnancy decision has to be the person who has to carry that risk. That was the argument we made in the Dobbs amicus brief, the first ever, about Black maternal health in the context of an abortion case. And my colleagues at the National Birth Equity Collaborative helped to pull that amicus brief together, and I co-wrote it with my good friend, Dr. Joy Creer-Perry. It was important that a human rights argument be made to say that the only deciders and the only decision makers, is the pregnant, capable person and the constellation of people around them. They choose to assist them. And for a lot of people, that's going to be their clinician, their clergy, the other co-parent involved in the pregnancy, maybe a mama or a grandmama, right? But that person gets to decide. So that's why I've been spending a lot of time with midwifery, because midwifery, the word actually really means being with women, with pregnant, capable people. And they have figured out incredible ways to be able to make sure people get the care that they need. So I'm about to end because I want to be able to get some questions and some comments and some discussions. So how does reproductive justice help all of this? How do we get here? Before the Biden and Harris administration came in, 90 groups around the country from reproductive health rights and justice put together a blueprint for sexual and reproductive health and what that should look like. And then we updated it for the administration with a whole set of principles and roadmaps and blueprints. And this is easily downloadable. I'll make sure that the link is provided in my slides. And then my colleagues and I, we said that there should be an Office of Sexual and Reproductive Health and Wellbeing at the cabinet level to be able, because we knew Dobbs was coming, and to really be able to advise the administration and to direct the Department of Health and Human Services and, a whole lot of other folks, the FDA, to really be able to understand what reproductive justice in the context of the White House could look like. And how do we really infuse that into the policies that would be necessary in order to protect, pregnant, capable people. So this document exists, and it has existed for a while. It's broken down, by everything from why policing is a reproductive justice issue to why, environmental justice is a reproductive justice issue. Whether you're talking about the water crisis in Flint and reproduction and knowing that that was associated with preterm birth, to looking at heat exposure in Fresno, California. We published those data during the pandemic that showed that prematurity and preterm birth was associated with extreme heat exposures, where you look at particulate matter and, environmental contaminants, that disrupt estrogen receptors and are associated with higher miscarriage in Black and Latina populations who do agricultural work. Right. So all of that is included in this very comprehensive report that 90 reproductive health rights and justice organizations signed on to. And it still is actionable. We just need some political will. This came out, and this is my second to last slide. This came out 2 weekends ago while I was at Harvard. And it is a list, and I'm going to read to you from some of this list about what this looks like, this visioning new futures for reproductive justice. Yeah, I think that's my last slide. So I'm gonna stop sharing because I'm gonna go out to this document and I'm just gonna read you the list because I think it's really important that people understand that reproductive justice is transformational. And it's not even a reformation or reform or a reimagine. It goes beyond that. So let me tell you what was written, what we're fighting for. A new vision of reproductive justice. We are dreaming ourselves into the future. Our vision is a future rooted in human dignity and worth, bodily autonomy, love, joy, and rest. Reproductive justice is our framework, intersectionality is our lens, and liberation is our goal. Liberation is giving the land back to Indigenous people who stewarded it and protected it for generations before colonization and who live on it today. Liberation is having what you need to keep your kids and care for your kids and to keep your family safe and together. Liberation is being able to have healthy and supported pregnancy options and prenatal and birth and postpartum care. This is the essence of birth justice. Liberation is choosing your family and being able to care for yourself and your community. It's mutual aid. Liberation is an end to police, prisons, and detention centers, which are harmed to design Black and brown bodies and to break up our families. Liberation is building communities where we all feel safe, able to experience joy, to live together with our loved one. Liberation is ending the war on drugs and providing physical and mental health care, help and support for everyone who needs it. Liberation is reparations. And liberation is abortion care for any person who needs it or seeks it. Reproductive justice leads to new futures that we do not yet know, but dare to imagine. We will not be silenced. We will take up all the space that we need. We will lead with love. We will reclaim our power for ourselves, our beautiful families, our children's, and generations to come. And so I ask this final question. Now that Roe is gone, that Dobbs is the law of the land, what's the plan? What new futures can we imagine and then construct? I hope that you will join me because I reject this as an ending and I see it as a beginning. So with that, I am happy to take questions, comments, feedback, discussion, and I am very grateful that I had an opportunity to follow the physician and the team who reported on the Flint crisis and blew the whistle. They were the first Riley lecture. I did look that up too. So it's been a real honor to be here, like with all of you, to be able to talk through this content. I know it was a lot. And, you know, I'm open. Oh, I'm myself on all social media platforms. I'll put that in the chat. I'm at McLemore MR. So that if you're in the shower like I am often and a thought comes to me and I never know how to reach back out to a person, you can hit me up. My direct messages, my DM on all platforms are generally open. If you get a question or comment or feedback or some kind of engagement that you want to do with me, like after this is over, if it comes to you later. I'm going to start with the first question and comment, which states, you have repeatedly said that we need to talk to people or to reach people. Well, how do you do that? I'm going to answer the second part of the question after I answer the first part of the question. Media training. One of the reasons why I get so many hits and so many like me, I thank the Op-Ed Project, which is a woman-owned group of people who decided that op-ed and writing for the public was too narrow and that needed to be disrupted. So me and my team, we've developed several kinds of media training for healthcare professionals. One is a rapid response. So I've done group op-eds with like 30 people because there's a formula that we use. And it's on my Medium channel. That's the other thing, right? I mean, I publish everything, including these comments, on my Medium channel. so that people can learn how do you do a rapid response? What's the anatomy of an op-ed? How do you speak out? How do you bring in new learners and earlier career people? I'm trying to get away from junior and senior because I think it's very patriarchal language. I don't really like that. So how do you support early career folks in really trying to, build that muscle of speaking to the public? Media training, rapid response, using our professional organizations differently. Right. I belong to 14 professional organizations: American Public Health Association, the American Nurses Association, Western Institute of Nursing, Academy Health. Like, we need to like scream better at our professional organizations that they need to be doing more in offering us these kinds of trainings. Right. I'm the journal editor of Health Equity. We've been doing Twitter spaces, trying that out to see if that's another way to talk directly to the public. Because guess what? We have more people who are not clinicians who join us on our Twitter spaces and on our TikTok page than we do at like registering for conferences or talks like this. So we've been hosting Dr. Elle Lett, who is a Black trans woman scholar at Penn. She's an MD candidate and a PhD in epidemiology. She's been hosting all these Twitter spaces for us because we talk right to people with lived experience, right? You have to be in the places where the public are at. So, media training, rapid response, be in the places where public are at. And then don't forget, I say this to people all the time, I'm a member of the community, right? I'm not just a researcher. I'm not just a nurse. I'm not just a scholar. Like, I ride the bus. I go to the community baby shower down the street when the doulas invite me, right? I am a member of the community too. And so for me, showing up as a member of the community, people see me in the grocery store. Hey, Dr. Monica, hey, how y'all doing? Like, I am a member of the community in which I live. And so one of the things that when we think about the segregation of healthcare, when we think about the underfunding of public institutions, you got to be in the communities that you serve. And I mean, showing up not just with an ask. I go to community baby showers because I live vicariously through other people, because like I'm aunt of the year to like 50 people's kids. Because that matters to me. I want to be a member of the community. I never wanted to be a parent because I don't want to live with kids. That don't mean I don't have kids in my life. Right? So we have to be more honest about that. We have to be more honest about our expectations of our villages. Right? I was so mad when public health came out with bubbles during the pandemic. I was like, oh, so we're going to get even more cliquey and more separated from each other. And people are going to think the world is even more polarized when that's actually not true. So how do we reach the people? How do we talk to them? I tell people, if you're not going to push out content, I did a whole Instagram live on this yesterday. If you're not going to push out content, at least lurk. If you lurk, then you can amplify the content of the evidence-based folks, right? Even if you're not going to push anything out, you're not going to pull any content, but if you're just going to amplify, right? Not speaking is a decision. And so even if you're just going to amplify the work of like, fact-based information, or, lab groups that you trust, or, public health people that are actually telling the truth. Like, that's one way to reach people. Okay, second part of your question. In talks like this, the Riley Lecture, you're talking to people who for the most part are already members of your choir. I don't have any choir. The only side I'm on is people I serve, just to be very clear about that. Because I've already said I've never had to make a pregnancy decision in my life, and people make all sorts of assumptions about what that means, but I have no idea if I ever had. That's why I would never put myself in a situation where I had to make a pregnancy decision, because I don't need that kind of uncertainty in my life, right? But if I had to make one, I have no idea what I would do. And people assume just because I do a lot of work in abortion, family planning, contraception, and all, like I'm a very pro-abortion person, I've never had to decide, so I don't know. How do you get to talk to those who most need to hear your message? Well, this is why I went to Harvard, right? They brought in, and this is one of the reasons why I've also agreed to continue to engage pro-life groups and scratch that, because I try not to use the anti-abortion groups, because they don't have a premium on being pro-life. I know a lot of people who are very pro-abortion who are pro-life, because they're pro-lives of the pregnant, capable person too. But like, how do I express myself in these subjects? Well, I get a good amount of death threats. And part of it is because I talk directly to people who want to cause me harm. And, I can't be the only person though, right? Reproductive justice is about a collective strategy, and it will never be about the Monica and the Monica show. It is about a theory, a praxis, a strategy where collectively And as a job, it's my job as a teacher, right, to activate your spidey senses and your, synapses and your neurons to get you to think differently about these things. So this isn't going to be about me. This is going to be collectively about a group of people who think that we can change the world, hearts and minds, and then actually do it. So this is why I'm a teacher. This is why I talk to students. It's one of the reasons why I left UCSF, because UCSF is a exclusively health sciences campus that only they have no undergrads. They only have schools of dentistry, medicine, pharmacy, and nursing. That's it. There's no undergrads. I've already told you, we start too late trying to get people excited about repro. So why would I come to another public university, University of Washington? Well, because we have undergrads. We got people right out of high school coming to college, right? We have people whose minds need to be activated, because I'm not trying to tell students what to think. I'm telling them how to think and how they want to think and what critical thinking means to them, right? So my job as a teacher is to help people unpack their own values, but then also, how do they like to think? What information sources do they need? Do they want to write about it? Do they want to see it pictorially? Do they want to hear from people with that lived experience, right? So for me, it's a collective, and then I need to policy people to do their job. So they have to be, hearing from constituencies, because it's representative government, right? And what kind of supports do we need? What do we think would help? How, what disparities do we want to reduce? Like, policy people have to do their side. But then we need like the service people to do their side. How we're going to provide care in a patient-centered, we want to listen to you. How can we get outside of that 15-minute appointment? Oh, I don't actually have time to hear your whole story. Like, how can we change all that? But it's multifactorial. And then we need to have community input. All of my work is community advised. And I'm starting to do community design work and community-led work, right? What does that mean, Monica? Well, what that means is I have a 24-person community advisory board right now of people that I've been paying from the start of the pandemic to advise us about the registries of pregnancy that happen when infectious disease outbreaks occur. So a lot of people don't understand that up until 1976, uterus having people were actually purposively excluded from clinical trials that were funded by the federal government. So now that we're trying to, get some parity around, so a lot of the data that we have around what cardiovascular disease and diabetes and infectious disease looks like in people is predicated upon people who don't have uteruses, right? So disease trajectories look different in those individuals. Like, it took us 20 years to figure out that the presentation of HIV and AIDS looks different in people who have vaginas and uteruses than it does other people. It took us forever to figure that out. And that's because the tissues are different. And that's because the way that people engage in sexual behavior is different. So we had to put all those dots together. But how many lives could we have saved had we included those people in the original clinical trial? That's a whole other discussion, right? But, we want to be able to design a public health, clinical health services, scientific enterprise that encompasses everybody across any reproductive trajectory. I'll give you another example of how to get at this scientifically. Dr. Lett, who I mentioned earlier, she said something as an epidemiologist that blew my mind when she said it, but she's absolutely right. She says, as a statistician, we have to stop excluding the other category, or we have to stop not reporting counts of small numbers in studies. And I said, well, Dr. Lett, why? Why? Because if we can't, in that study, if we can't statistically do anything with those numbers, then why would we report the counts? She said, because had we done that in every study that's been conducted, let's say around diabetes and, race and ethnicity, we could have used tools like meta-analyses where we pool data together to actually get an accurate count of what we think the estimation of diabetes is in Native Indigenous populations. Because even though no one study would ever have enough Native Indigenous people in it, we could have pooled all those data and gotten some population-based estimates based on geography. I said, damn, yeah, you're right. But we didn't really move forward with meta-analytic tools. We had to map the human genome first, right? So as we think about what DOPS has done for us, one other piece I want to push people to think about is measurement. We've always thought about maternal child health indicators as the health or barometer of the nation, right? We look at early entry to prenatal care, we look at infant mortality, we look at maternal mortality. That means nothing in the context of Dobbs, right? If you spent a month driving around trying to get a wanted abortion somewhere and you were unsuccessful, stigma, shame, judgment, and blame, depending on what state you live in, is probably going to keep you from telling your healthcare provider that. So you're just going to enter prenatal care late, which is why we never should have been asking the question, like at pregnancy intakes, like, early entry to prenatal care. We should have been asking people, have you sought care from any healthcare provider or entity for this pregnancy? And if the answer is yes, when did you seek that care? That is a more scientifically precise question that gets us at more important information. But early entry to prenatal care as a variable means nothing in the context of Dobbs. Or if you think about how people use marital status as a proxy in their research studies, that has never meant anything when you're studying Black people. Because if two poor Black people get together and decide they want to make a family and they have a baby, that's 3 poor Black people trying to live on the income of 2 poor Black people. Like, that doesn't make any sense to me. It never has. What are we trying to capture when we measure the variable, marital status? It's a proxy for income, right? Why are we still studying proxy? So when I say we need to reach the people, it's not just patients or people with lived experience. With the scientific community needs to be reached too. Those of us who are utilizers of health insurance need to be reached. The payers of health insurance need to be reached. And usually those are the employers, right? So everybody needs to be reached. It's not just y'all. That's why I send out my slides, I let stuff get recorded. I want people to live tweet stuff, because we need to recreate the public exchange of ideas. Because for too long, we relied on print media, news, all of that, like we haven't caught up to where are we having these conversations and how can we build skills to be able to have those conversations. I hope I answered your question. Okay, let's see. Monica, I have a comment and a question, but I'm a faculty member. I'm hoping we can, oh wait, now it's moving. Prioritize student questions. Yeah, students, y'all, somebody want to unmute themselves? Like, how much time do I have? Because I told y'all I'm challenged.
Yeah, it's 6 minutes before the program officially ends. But we can spill over a little bit, right?
Yeah, well, I'm hanging.
Are there any students who wanted to put a question in the chat?
Or unmute yourselves, because there are 2 others that I can answer that are in the chat right now. All right, well, I'm gonna keep talking until we see a hand. Y'all put something in there, because these questions are really important and they're very good ones. I can't believe that in some states, women have to file for disability to have time off work for a miscarriage. Do you know that you also don't, if you have a miscarriage or an abortion, most employers will not allow you to extend your leave, but that's a whole other discussion. And yes, we need to reimagine the insurance and the coverage that people get just for pregnancy, period, because having to apply for disability means the state now knows that your pregnancy has either ended or it's ended, and that's a whole privacy issue. But okay, many companies have opted to cover this type of leave, not all though. How do we better influence policymakers to have a more human-centered approach? Well, the momnibus has been languishing in the last 3 Congresses, introduced by the Black Maternal Caucus, led by Rep. Alma Adams, who has a PhD, and she's from North Carolina, and Rep. Lauren Underwood, who is from Illinois, and she's a nurse, and she went to Hopkins. The momnibus has money in this to be able to really reform some of these systems. Now, $1 billion, and that was 9 bills before COVID, and then it became 12 bills under COVID because we had to have the maternal health protections around COVID. So only 2 of the momnibus bills have passed, and 3 have actually gone through as part of the Build Back Better and the infrastructure bill, which is great. So we'll be getting better data in terms of looking at how, if we were going to move from disability, because again, the federal government is always trying to think about how can we leverage existing infrastructure. one thing we've cautioned them not to do, what they did during COVID, is to just move everybody to the Medicaid and or the Medicare infrastructure that already exists. Well, that doesn't make any sense, right? Either we're going to have to build something within the ACA that will allow for, like pregnancy coverage to be able to be expanded, but not under the disability system and not tied to employment, right? We need a consortium of people thinking about how to do that in a way that's least disruptive. And one of the other bills that was within the omnibus that actually is coming through the infrastructure bill has put forward a study from CMS, the Centers for Medicaid and Medicare Services, to partner with the National Academy of Science, Engineering, and Medicine, which used to be called the Institute of Medicine, to be able to actually get at healthcare financing. Like if we took the money that hospitals, birth centers, and everybody gets based on birth in the global obstetric benefit, could we carve out enough money to be able to cover pregnant, capable people, irrespective of their employment, and not having to utilize the disability system? And could there be an employer match, which they're currently doing in the disability system? Could that occur so that we could get no-cost birth and no-cost doulas and other kinds of social supports for individuals? That study is going to be coming out soon. I'm super excited about that. So yes, I agree with you. Okay, second part of your question. Do you feel that companies are stepping up in bigger ways in lieu of public policy, and that corporate world is becoming larger opportunity to drive this type of change? Yes. I mean, when Lyft first came out, they were one of the first companies out the gate, along with Salesforce, to say that they would pay for their employees to travel for abortion-related care. There are corporate leaders who get that pregnant, capable people should not have different access to healthcare than other folks, but they can't drive that change. They don't have the levers in the same way that the federal government does. So they can push, just like we're going to need philanthropy's help on this too, right? So it's got to be philanthropy, it's got to be the federal government, and it's got to be employers, because we're going to need all three of those domains to be on the same page around, like, how do we move care forward for pregnant, capable people, and how do we as a society then create that social safety net that's necessary in order for everybody to optimize their outcomes. So we're going to need philanthropy on this too, in addition to, like, not just employers, but and you can't be lucky enough, because again, we have to go back to 1 in 6 hospital beds in the United States are owned by a religiously affiliated institution. 1 in 6 hospital beds in the United States are either run by, Jewish charities, Catholic charity, like. So this isn't going to be the same for religiously affiliated institutions, even if you work at one, but you don't subscribe to that religious orientation. So there's still going to have to be some discussion around what's the baseline minimum that we want to see. That's why employers can't drive this, at least not on the healthcare side, because there's some employers who are not interested in providing a full range of options to the people that they serve, whether those people believe the same religious orientation of the institution or not. So that's why we need philanthropy, and that's why we're also going to need the federal government. Okay. I want to answer this question though. Professor, how do you decide in the context of the Dobbs decision where to retrofit and where to reform? Aren't there reproductive justice related conditions with regard to which retrofit is to capitulate and accommodate, that is to accept the unacceptable? I'm about harm reduction. Abortion has been banned in states. We have surge states specific to abortion acts. It's not the only, but like right now we accept this in infertility. We already accept the unacceptable, right? And spinning our wheels, thinking about that, I think is not helpful, because that's already been real for a lot of people. Even when you think about the clinics, like the states like Tammy Kromenacher in North Dakota, she was the only abortion clinic there for years, and we let that happen. And now she's moved her clinic to Fargo or to Minnesota, across the bridge, right? People already had differential access to services. There was already disparities in that. So I'm not saying that to like circumvent your question or abdicate its responsibility, but it's both and. It's not an either or. And reproductive justice would teach you that in some places we're going to have to make some very strategic investments. And in some places we're really going to have to think about, okay, maybe it's not the federal government's role to work on that, but maybe that's where philanthropy can be helpful. Or maybe that's where the employers are all teaming up together. But it's not a either or. Retrofit, I am remiss to say this, I'm glad you asked this question. Retrofit, reform, and reimagine is not linear. It's a circle. And we need all three at the same time. So I know conceptually that's a lot, but it's not a linear process. It's not that you retrofit one thing and then you reform it and then you reimagine. No, it's actually a circle. And we need all three to happen at the same time. And so if I represented it as a linear process, it's not. That said, in some places, retrofitting people access to self-managed abortion in a safe way, and knowing that nurses are not going to call the police on them, like what happened to Lizette Hernandez in Texas around her miscarriage and self-managing, knowing that, to me, that's harm reduction. Yes, that's a retrofit. No, that's not acceptable. But teaching nurses around the code of ethics and the need to be able to provide care is a retrofit. So yeah, I feel you on that tension, but it's a both and. Right? Congress could fix all of this if they really wanted to. And this is another reason why voting rights are a reproductive justice issue. Because if they pass the Women's Health Reproduction Protection Act that Patty Murray and the vice president and a whole lot of other people worked on, they could have codified the protections of Roe. Congress could do this. So maybe it's time for a different Congress. Anyway, I know we're at time, and like I said, I'm happy to continue the dialogue. Hit me on socials. I'm myself everywhere, McLemore MR, on LinkedIn, Instagram, Facebook, Twitter, TikTok, Medium, YouTube, because we need more people believing that change is possible and that we can crowdsource how to do it, and that we can actually get better. Because I want to leave this audience with a controversial statement, and that is Roe was never the best that we could get. It really wasn't. The word physician is in the Roe decision more than the word woman is. That was really to decriminalize abortion for physicians. But the word physician appears in the Roe decision more than the word woman does. It was never the best we could get. Reproductive justice is better. So I hope that was helpful. I hope y'all have me come back. I really appreciate you all.
Monica, thank you so much. Thank you so much. We're just a couple of minutes after 7, so the time that we had planned is up, and I know people are maybe disappointed that they didn't get their question, but they could, like you say, catch you on your socials. Yeah,
catch me on my socials, and like I said, you'll have my slides, and it should have the references that I cited in them. And I just keep doing the great work. I mean, you've got an incredible opportunity, and thanks again, to the purveyors of this lecture and the Riley lecture and the families that are supporting it, and to the audience. I'm deeply grateful, and we can make the world different. I need more people to believe that.
Yeah. Thank you. Thank you so much.
Thank you. Thank you. Have a good rest of your night.
Thank you. Thank you so much. Thank you. Thank you. Really appreciate it.